I am honored to introduce this morning's plenary speaker, who really needs no introduction. She is an editor-in-chief for the international peer-reviewed journal, the Journal of Nursing Administration. She's also Chief Operating Officer and Chief Nursing Officer at Baptist Health Lexington. She's a faculty member at the University of Kentucky College of Nursing and a fellow in the American Academy of Nursing. She is renowned for her expertise in leadership development, her knowledge in intergenerational workforce issues, and her proficiency on effective strategies on nurse retention. She is co-author of a newly released book, Establishing a Research-Friendly Environment, a Hospital-Based Approach. After this session, meet Dr. Hill at the Leader Shop. When Dr. Hill was appointed editor of Jonah in 2011, she said her vision for Jonah was for the journal to be as dynamic as the role of the nurse leader. She certainly has lived up to that promise. Please help me welcome Dr. Karen Hill. We have something else. Today is Dr. Hill's birthday. Oh. So she is celebrating her birthday with all of us. So don't you think it's fitting if we all sing a happy birthday?
Oh, thank you.
So we're going to do on 3, okay? We're going to start, and you have to be loud, because when I told my family we were going to be doing this, they said, uh-oh, you don't want to hear you. So all of us. 1, 2, 3.
Thank you. Thank you. Thank you. Okay, AONL gets the award for the most interesting birthday I've ever had. Although, I'll tell you my second most interesting birthday. When I was 26 years old, I was working as an operating room nurse in the hospital where I'm the chief operating officer now. And I went to work that day, and I was due within a couple of days. I left to go to a doctor's appointment, went out to lunch, had dinner with my parents, and had my son before midnight, just like any other nurse. So, and I tell my staff, we joke around a lot about it, because they know I'm I'm a deadline-oriented person. I'm an editor, and so deadlines are fairly rigorous. And I tease my staff, and I tell my husband, we have to have sex in September because I got to have this baby during intersession. Because I was in graduate school, or no, I was in my bachelor's program at the time, and I was trying to finish my bachelor's, and I was working full-time, and we wanted to have children, and you have to fit it in, you know, so anyway. Thank you for being here today. It really is a special day, and I'll tell you, it's one of the biggest honors of my life to get to talk to nurses who are like me, because I appreciate what you all do every day, and I do what you do every day, except I have the special blessing on nights and weekends to be the editor of one of my favorite journals that I've used for years in practice. Today we're going to cover some things, because you know we're nurses, we have to have objectives. So we're going to talk about some emerging issues in nursing leadership and research. One of the things I want to do is profile a few articles from Jonah to let you see some interesting things that could either apply to your practice, things that you may want to replicate in your own sites, or things that may spur an idea of a different kind of project. And then we're going to talk about creating a research-friendly environment in your organization or your unit or your department, and give you some tips about how to do that. Jonah, one of my favorite topics. I've been the editor since 2011. I succeeded Dr. Suzanne Smith, who'd been the editor for 30 years. And she was honestly one of the most gracious nurses in a transition that I've ever seen in my life. And that gave me a lot of lessons about being gracious with other people when you have those transitions. Jonah is proudly the official leadership journal for the Magnet Recognition Program, something that's been in place since about the year I started. And one of the things I wanted to read for you, every year we do a special supplement with Magnet, and they pick some different topics to do a focused supplement that they pass out at the Magnet Conference. And this is just an example of some of the topics where I think it shows how right on they are with some of the issues. Healthy work environments supporting nurse safety and satisfaction, the value of Magnet, Magnets Supporting Patient Safety, Nursing Workforce and Implications for Nurse Executives, and the Role of the Nurse Manager, Pivotal to Magnet Success. So I think you can see how right on they are with things that are emerging issues as well. We circulate JONA in over 142 countries, and I'm very proud of that, and we get a lot of international submissions, and that's one thing I've always loved is that nurses are international. Our impact factor is something it's a literary indicator that they use when they measure manuscripts. We're a double-blinded peer-reviewed journal, and that means that I send the articles that we choose to send out to 2 expert peer reviewers, and the authors do not know who does the review, and then I blind those reviews when they come back before they go back to an author. What the impact factor is how much we are respected and used as citations the 2 years previously to the measurement, so they're always a little behind. But it says a lot about the journal when the articles that are written are well respected enough that people want to cite those in other literature. We publish 12 editions a year. We do 11 regular editions, and we do the supplement. And when I talk about articles, I'm going to try to focus on things in the last couple of years. If you've done publishing, you know that really in the journal world, you really want things that are very current, and so the last 4 or 5 years. One of the things that's tough is that we're a hard journal to publish in. Now, I think that makes us a desirable journal to publish in because people want to be in JONA. The acceptance rate is about 15% a year, but what that means is 15% of about the 350 manuscripts a year that we receive have minimal changes, even from me, before they're sent to the copy editors to be put into a PDF. But we accept a lot more than that, and I often will accept papers from first-time authors. In fact, I had a nurse that was working on her PhD that a couple of years ago submitted part of her thesis, and she had turned it into a manuscript, and it was a really good one. And after she got accepted, she emailed me back and she said, "You're my first editor." And I thought, that's really a great feeling because it reminded me of how I felt when I had my first nurse helping me with in-service when I was a new grad. And so that is a huge feeling for me of coaching other people and how much I appreciate the role that I'm in. In 2014, JONA was cited in an international work for a period of 10 years as the most cited nursing leadership journal in the world. And so I was very proud of that, had no idea, and somebody sent me the article. Okay, so this is my day job. This is a picture of what my hospital really looks like. It's Baptist Health Lexington. It's located in central Kentucky, and which is really a beautiful place. And right now we have horse races going on, and you know that the national holiday, the Kentucky Derby, is coming up in a couple of weeks. And that's a big deal. And this hospital really looks like this, and one of the things I'm the most proud of is that the building with the glass over on the side was designed by nurses. Now, one of my roles as a chief operating officer is I get to be in charge of everything, and honestly, I believe nurses can do it better anyway, so I'm good with that. But we designed that building. Yeah, you are. We designed that building, and I get ideas from a lot of people, which is one of the reasons why I want people to publish. Because my staff, I've been the chief nurse there for 28 years in the same hospital. I was a candy striper there when I was 14. And one of the things that my staff tell me, they say, "How do you keep thinking of all these ideas?" And I'm honest with them. I have very few original thoughts. I learn a lot from people who take time to publish. Because when you do something great and you let other people know about it in writing, it lives forever. And I really appreciate that. And so every dilemma, clinical issues, where I just need a new idea, I want to tap into somebody else's brain, I go to the literature. In this building, one of the things I was able to do an exchange program in New Zealand about 15 years ago for women's health, and they had patios outside the units, and I thought, what a great idea. And so on the building that we built, every nursing unit has a patio on the end of the unit for patients and families to be able to get a breath of fresh air when they're there. And then, of course, I had to argue with the risk managers that nobody was going to jump over, so there's a little thing there. But anyway, it's a great building. A couple of more things about Baptist that I want you to know. One is we're a 3-time magnet hospital, all under my leadership. In fact, I wrote the documents the first 2 times, and then my very gracious husband said, "You might as well go get a doctorate if you're going to sit there and write all the time." And I did. And then now we're in our cycle for our 4th designation. We're in the first group of the 2019, and our documents are with the surveyors right now. And if you're in the audience, I know who you are. And the last thing I want to tell you about my hospital is we have been able to create a really research-friendly environment. In the last 6 years, this normal community hospital in Lexington, Kentucky has generated over 60 peer-reviewed publications, with more than 1/3 of them having a staff nurse as either the lead or co-authors. And so I'm very proud of that. And I'm going to tell you today how to do it. So what I wanted to do, since we kind of have a limited amount of time, is I wanted to talk about what were the biggest emerging issues that I saw in the literature. And you know, I read all these manuscripts, I read every one of these manuscripts, and so I have opinions about what I thought were the most predominant issues, but I went back and did a search for a couple of years, and they fell into three general categories. The first is the nurse manager, and I thought it was ironic that that's the focus of Maria's research. It's such an emerging issue, and it's still an emerging issue for all of us. And so we're going to talk about that a little bit. Nurse managers have very complex roles, and things that have been published in just a few of those topics are competencies, the engagement not only of the nurse manager, but the role of the nurse manager engaging others. Shifting and honestly very complex accountabilities and responsibilities. I know we have really burdened our nurse managers with so much today. They're the chief retention officers, they're the chief strategy officers, they have to make sure all the patients are happy, they have to meet their budgets, and they have to manage a million metrics. And oh, in addition, they have to have a life. Millennial nurse managers is a hot topic right now, and I have a really interesting article coming out in JONA in July and August on the lived experiences of millennial nurse managers. And I think it's really great, and one of the quotes that's in that article, I love it, and I'm going to read it for you. This millennial nurse manager said, "I am a nurse manager for a $1.2 million budget, and I don't balance my checkbook." One more thing I wanted to tell you about the nurse managers. Nora Wojcicki, who you saw in the video, and is a very prolific nurse manager researcher in her own right, did a study, and in her study, the sample size that she looked at, 72% of the nurse managers in her sample were going to leave their jobs within 5 years. So I think we have to pay attention to that group. The second group we're going to talk about today is work environment, and it's really important. Those studies that relate to work environment are something that are critical. We need to look at the continuing issue of nursing fatigue. Resilience and burnout, you hear a lot of interchangeable terms, are very important, as well as something that's passionate to me and to the ANA is nurse safety. Working with millennials in a different perspective in the work environment, having them be on teams, almost 50% of the nursing workforce right now are millennials, and we have to learn how to work with them, how to engage them, and how to maximize that talent and capability. The third category of studies that we're going to look at today are studies about advancing patient care, and in that are the research environment studies, studies about what you need to have to use technology to your advantage. So we have to have a common platform of what we're going to talk about today related to the nursing workforce. So let's frame our knowledge about that just a little bit. RN jobs are increasing, and in studies in 2018, 45% of the hospitals added nursing jobs, and I know I have. I've added nurse navigators, I've added nurses in the quality department, infection control, we've added some charge nurse positions, we've added nursing jobs. And in addition to that, I have a lot of nurses that are graduating nurse practitioner programs, creating vacancies, but they're getting into other new nursing jobs. I think the cost of turnover in the United States is severely underestimated. I don't know about you, but I'm in Southeast United States, and I cannot cover turnover of a nurse for $61,000 because they give you a month's notice when they leave. It takes you, well, and we have a budget control committee, like I bet everybody does, and then you have to submit the request to the budget control committee, and they have to decide if they want to let you replace it or not, and then you get to post the position, and then you have to go through all of the applications, and then you bring people in to interview, and then you want to make sure your staff get to meet them and tour the unit, and then they have to give a month's notice wherever they're coming from if they had a job. And it takes me, honestly, 8 to 9 months to replace a nurse. So I think we've underestimated that. And probably in our business case for more resources, we underestimate that. One statistic I did want to show you, because I do think this would be helpful in a business case, is 1% decrease in turnover of nurses is worth about $337,000 a year. That's a big deal. 83% of the hospitals in the United States have reported that they have a strategy for retention, but only 40% can tell you what it is. And it reminded me of a paper that I did with Robert Wood Johnson. Seriously, we did a study in 2006 with a group of cohort members from Robert Wood Johnson, and we wrote a paper on wisdom at work, and it was one of the best projects we ever did because we looked at nurses over 45, which we considered seasoned, and how do we keep them engaged in their jobs. And we interviewed a lot of employers about what they thought was important about keeping older nurses in the workforce, and many of them said that they had a strategy about it. But when we asked them what their strategy was, very few HR people, nursing leaders, or hospital administrators could tell us what their strategy was. So my point in this slide is, if you don't know what your strategy is for retention, you may not be able to communicate it to other people. So you need to say it, write it, and measure it. By 2024, we're going to have over 1 million jobs open in nursing between the baby boomers retiring, between nurse practitioners going off into other kinds of roles besides clinical bedside roles. And then we, of course, have new jobs being added. This is a really big deal. We have a significant workforce shortage on the horizon. In 2017, U.S. nursing schools turned away 56,000 qualified candidates for some of the same reasons that I'm talking about. Faculty retiring, resource constraints, abilities to handle bigger classes, and sometimes competing priorities between degrees. And one statistic I thought was interesting is 63% of the nurses in the United States now work in a hospital, either an inpatient or an outpatient setting. Now, this year, I've been a nurse 41 years, and when I've graduated, probably 75 or 80% of the nurses in the country were associated with a hospital. But today, think about it. We've got all kinds of alternative care settings. We've got people who are getting care in 1 million different locations, some with and without hospitals. And what I think this does is this challenges us a little bit to look at our paradigms of nursing and where we cover ourselves. As far as a nurse leader, I know it's easy for me to think about the boundaries of the hospital, but in reality, I'm the nurse executive for people in the medical group. I'm the nurse representative and executive for people who are in some of our agencies, like our home health agency and other licensed agencies in our corporation. So it's a really big deal for us to think outside the box. We had an interesting guest editorial in January in Jonah from Carol Boston-Pleshauer, who's the chief nurse for the Nurse Executive Center. And Carol challenges us to think about traditional undergraduate nursing education, and do we really think it has to be so contained in a hospital, and are we shortchanging nurses and practice settings by not having other kinds of options for nursing education? So let's talk about nurse managers. We're not going to go through this slide, but I thought I would do this just so you could see the voluminous, and there are a lot, of different kinds of topics related to nurse managers. And Joan has published studies on all of these, and sometimes multiple studies. So this is one I do want to talk about for a minute. The perceptions of professional leadership coaches regarding the roles and challenges of nurse managers. And it was a qualitative study from the perspective of 11 professional coaches. And so they interviewed the coaches about their work with these nurse managers. And the nurse manager was described as someone with 24/7 accountability for one unit at least. So what do we know about coaching? I think all of us believe that coaching is important. I know I hired a retired nurse educator about 10 years ago on just an hourly salary as a leadership coach for my staff, and it has been such a huge success, and she's just not expensive, but she's amazing. And what she does is she's known to the staff will email her, she confidentially will talk to them about changing different specialties within the hospital. She gives them advice on going back to school and where might be a good fit for them. Sometimes she'll talk to them about an issue that they may have related to trying to decide what they want to do, but coaching makes a difference. Coaching assists in the identification of opportunities for advancement, and that's one I believe is our responsibility to help people try to decide, how can you be strategic with your career? You know, great careers don't happen. You have a goal, you have a strategy, and you work towards that. Coaching in new ways can be thinking about leadership and about challenges. It's something that we all need to sometimes have that outside perspective, that maybe what we're doing is not the only way to do it. So in this study, they asked 4 questions. They said, why coach nurse managers? Now this is to the coaches. They asked them, how do you have the experiences of nurse managers differed from other leaders? Most of these coaches said the majority of their work was with the C-suite. Why did nurse managers seek out coaching, and what was the most valuable contribution of a coach to the nurse manager? So for question number 1, why coach a nurse manager? It was 2 really predominant things. One was a desire to provide a needed service. These coaches recognized that this was something nurse managers needed, and recognition of the value and role of the nurse manager. And one of the quotes I thought was significant is, coaching provides the nurse manager an additional support system. And I think if you've been promoted from within, it's an isolating experience, and sometimes I think maybe we've overlooked the opportunities where somebody could be an objective coach to a nurse manager and give them sort of that support, especially through the first couple of years. So why nurse managers seek coaching? 1 is professional role development, and 2 is how to handle conflicts. Conflict management comes up a lot in the literature related to nurse managers because staff want a unit where the nurse manager is able to deal effectively with conflict. And you know, it reminds me, I talk to nurse residents a lot at our hospital, and I ask them, what do you wish you learned in school that you didn't learn that you want us to teach you now? And they tell me 3 things almost every year. 1 is they're scared they're going to kill somebody with meds and pumps and drugs. 2 is they don't know how to communicate with the physicians, and honestly, that's a really big lesson in that one. And 3 is they don't know how to handle those crucial conversations when something doesn't go right. So you're standing there and they call a code blue on a patient and they've been married for 60 years and you've got this wife and the husband's the patient and you've got a brand new graduate and they don't know what to say. And when I look at this, I think with nurse managers, they don't know how to handle conflict until we teach them. And so it's really important, and I thought that was a great epiphany. The second question that we need to talk about is the quote that they talked about was, I want to help nurse managers develop professional presence. And I thought about conflict management, and I thought that has a lot to do with professional presence and confidence. And a couple of other quotes from this study: nurse managers experience a higher level of stress than other leaders, and I believe that's true, and that's been substantiated that they have a lot of stress, and that the most valuable contribution of these coaches was to help them gain a self-awareness. The quote at the end, which I thought was really enlightening: nurse managers play a crucial role in our healthcare system. Challenges that they confront are widespread, and unfortunately, they may be inadequately prepared and developed for their roles. Okay, I love this one. I got a story to tell you about this one. The title of the article is A Survey of Nurse Leaders to Explore the Relationship Between Grit and Measures of Success and Well-Being. And the lead author in this is Dr. Claire Seguin, and I have to get her title right here. Claire is the Associate Chief Quality Officer at Mass General Hospital in the MD Network, and by the way, she's the first nurse to serve in this role, so I'm really proud of her. So I asked Claire, I said, well, when I got this article and it had grit in the title, one of the things they teach you as an editor is titles make a difference. You want to make sure the title is something that reflects the article and the topic that's covered, but you want to make it where if somebody's doing a Google search or they're looking for things, they want to read your abstract and they want to read your article. So I emailed Claire and I said, are you sure you want grit in the title? And she said yes. She said, I feel pretty strongly about it. She said, I measured grit. I want to make sure that people understand that that's what we're talking about. And she got inspired by Dr. Angela Duckworth doing a TED Talk. And that's how she got the idea to do this study. So what she did is she explored the personality trait of grit and how it impacts the well-being and success of nursing leaders. And ironically, I thought it was interesting since we're here today, the majority of this sample were AONE members. So Claire defined grit based on Dr. Duckworth as a perseverance and passion for long-term goals, not just resilience in the face of failure, but a deep commitment that you remain loyal to. And that struck home with me, because when I think about nursing, I think about commitment and passion. And then it was ironic because, you know, sometimes they say the customer's always right. She was right. And while I was processing her manuscript, Dr. Daniel Lee from Prescaney and Angela Duckworth printed an article in Harvard Business Review on organizational grit. And I emailed Claire and I said, you are so right. And so one of my lessons learned is, if you think you're right and the editor's not right, you tell the editor they're not right. It worked. She got published anyway. Okay, so one of the things they said is grit propels people to the highest ranks of leadership in the most demanding fields. And I think that's true. When you think about it outside nursing and healthcare, they have to have grit, perseverance. So the findings were the grit scores increased with years of experience, and the age where they kind of reached their epitome was a little over 8 years. Higher grit scores were associated with increased sense of personal accomplishment and reduced sense of burnout. And nurse leaders with higher scores on the grit scale were categorized as lifelong learners, and they sought advanced degrees at higher levels than other leaders. So what are the implications for you as a nurse leader? Well, measuring grit, which you may not have thought about before, but you got to read this article, and my publishers allowed me to make this free for a month on Jonah's website, so take advantage of it for the next month. But you can pay for stuff other times. Yeah. Measuring grit can be one way to identify future leaders. Conversely, very high levels of grit may close you to outside opinions on things, so there's a balance there. You need to further explore the presence of grit in teams and why nurses leave our profession. Those are things we want to learn something about. And I guess the last one I think is really important is, if you're a nurse leader and you want to have a team or a leader that you want to sense a higher level of grit, how can we as a leader help them do that? So implications for future studies. Now let's talk about work environment for a minute. Work environment is a hot topic. Everybody wants to work in a healthy work environment. In the literature, there are some things that are common, and you see them over and over again related to a healthy work environment, and I listed a few of them there just so we'd have that understanding. One is improved job satisfaction. Work environments are related to improved job satisfaction. Improved retention. Staff tend to stay in environments that have the characteristics of a healthy work environment. And that's in any field. That's not just in nursing. Improved psychological health of nurses. We have a stressful job. Our staff have stressful jobs, and healthy work environments manage that. Increased job performance and productivity. You know, I think about myself in my own life. I've got 1 million units. I got a lot of telemetry units. My nurse directors that work with me are like a family. I've got people that are high performing, I got those middle people, and I got a couple I watch a lot. And they know I'm watching them because I'm coaching them, and they really know I'm watching them when they get to come and see me every couple of weeks. Yeah, they want to get off that list kind of quick. But anyway, improved job performance and productivity is a characteristic of a healthy work environment. Better patient outcomes, we all want that. Improved nurse and patient safety and the quality of nursing leadership. So this is a study that was a couple of years ago in Jonah, and it looked at measuring a healthy work environment and the direct care nurse's perspective. Dr. Penny Huddleston and some people from Texas were the nurse researchers, and they defined a healthy work environment as a setting with policies, procedures, and processes designed to empower nurses to meet the organizational objectives and achieve personal and professional satisfaction. Sounds like what we all want. This is a qualitative study. It was conducted using focus groups at Baylor Scott & White with their North Division. And the nurses that participated were either managers with 2 years experience or nurses that were not new graduates or agency nurses. Some of the findings of significance, and this makes sense, nurses care about staffing. You know, it's almost like Maslow's hierarchy. If you don't have appropriate staff, how can you do anything else? And, you know, staffing is complicated. Sometimes staffing is considered very simple. It's a ratio. Well, it's not just a ratio, and you all know that. A patient's not a patient, and a nurse is not a nurse. I think we can agree on that one. With staffing, you have to consider the acuity, and I keep trying to tell my finance leaders, the patients with the lowest case mix are the most acute patients for the nurses because they're the ones with the emotional issues, they're the ones with the behavior issues, they got all these complex family dynamics, and it's not always reflective in a case mix. Skill mix of the staff on the team is important for appropriate staffing and for the perception of staff, as well as census and support. Support on the unit, I haven't seen it as much lately, but I used to see a lot of articles about people who were trying to reduce expenses, and they would cut a lot of support for the unit so that nurses got stuck doing things that they didn't always need to do. And you know that contributes to productivity and satisfaction. And I put churn on here, and I took the liberty to do that, and I'm not an author in this study, but I wanted to put churn on here anyway. Because to me, we have to teach people that what happens for the 24 hours before midnight is workload. And that's one of the things that I appreciate that sometimes we haven't been able to do. Now, I would love to have one of you in here, if anybody has equal staffing on day and night, it is not something that I've been able to accomplish in my career, but I would love to see a good study on the cost effectiveness of equal staffing, because honestly, just because we've had lower staff on night shift ratios does not mean that it's the right thing to do. And 40 years ago when I got out of nursing school, people did used to sleep at night, and they don't sleep at night much anymore. And so we really have to look at the acuity of night shift, and we have to wonder about the support that we're giving them. So if you've got equal staff, I'd love to have an article from you on your outcomes. Authentic leadership was one of the findings. People want a visible leader. They want someone who's fair. They want people to be transparent and tell them whenever there's an issue or what we have to do about it or direct feedback. And they want people who communicate, and communication is a big challenge. Effective, oh, this is funny. Okay, so in the article about millennials, they talk about millennials needing, they grew up using texting, you know, so they get answers really fast. So when they come to their nurse manager and they ask you to do something for them and it takes you 2 weeks, you think you're pretty fast, but they're used to like 2 minutes. And so one of the things that they suggested in the article is you may want to at least let them know you're working on it every now and then, because a millennial may think they got ignored because you take 2 weeks to get back to them. Effective decision-making is a big deal, and they want decision-making based on evidence, and they want to know the evidence. We're really smart. Our staff are smart, and we need to tell them the evidence and why things need to change. Meaningful recognition, both public and private, and this is something that I'm particularly passionate about. In our book, I label something called generous leadership, and what I mean by that is a person in a leadership position who is confident enough in their skills and with their own self-assurance that they are totally generous to others. And when I say generous, I mean putting people in positions when they can get the recognition, helping to support people to accomplish the things that are important with them for their careers, recognizing every nurse that gets certified in your hospital and every nurse that goes back to get an advanced degree, and when they get to have a podium or an abstract accepted someplace. It's letting people know that, and I believe in that, and I think that's what we all want with people we work with. Meaningful recognition can go way beyond just that kind of thing, but I think we don't overlook it. You know, one of the things that nurses don't do is they're very humble. And you can get an article published in an international presentation and your boss doesn't even know about it. Now that's pitiful. And so one of the things that I've always tried to do is I've tried to make sure that somebody is a nurse supporter for every other nurse. And when you do something good, if you're embarrassed to go tell somebody you did something good, get your nurse supporter to go tell somebody for you. And then you tell them for them. And it works. And believe me, I've had nurse supporters my whole life and I'm doing it for other people. And it comes back in bounds. Skilled collaboration is a big deal for nurses. They want people to be empowered. They want people to get along. They want the teams to have goals that are aligned. They want to know where they're going. And then physical and psychological safety, and I think we cannot underestimate that. Okay, I love this study. This is interesting. This took two groups of new graduates in two different segments. One group of nurse graduates was in a nurse residency program from 1999 to 2009. That's called Group 1. Group 2 was 2011 to 2016, and that's Group 2. And both groups participated, and this is multiple sites. This is a bunch of hospitals. The nurses participated in the Versant New Graduate Nurse Residency Program. Now, I wasn't as familiar with that. The program is a standardized transition to practice program. It averages 18 weeks. It has preceptorship. It has mentorship. It has debriefings, and it has a 360 degree, so it sounds pretty comprehensive. So what were the findings? Well, they said Group 2 reported higher scores for perceptions of work environment and leader empowering behaviors. Now, I was really glad to hear that because if you surveyed my staff 10 years ago and you surveyed now, I hope we're a little more empowering than we were 10 years ago. So I thought that was a good finding. Millennials saturated Group 2, that's not unexpected. Nurses in Group 2 reported organizational loyalty but high turnover intentions. Okay, now think about this. We got millennials. They want things quick. I got people in the new graduate orientation programs who are bold enough, they want my job. And I think that's really great. And a couple of them, I had this one, he was young, he was really bold. And I say, you know, tell me what your career goals are. And this kid looked at me, I mean, he's 23 years old, and he said, I'd like to have your job. And I said, well, come follow me one day and you need to get a master's degree. But honestly, they don't want to wait. They're not going to serve term. You know, they want it now. And so we've got to help manage that. Millennials valued personal attention and supervisory support, but they reported it as less prevalent than the people in Group 1. Now, I'm going to extrapolate a little bit and think that maybe that's because they wanted it on a different level than maybe Group 1 is willing to accept. And nurse leaders are important to both new graduates and both cohorts. So I think, again, it reinforces the role of the nurse leader. Okay, the third topic of studies that we're going to talk about are advancing nursing practice through research and the application of evidence. And it doesn't sound that exciting, but it really is. Okay, and this is a good one. Okay, the first study is going to be the National Study of Nursing Research Characteristics at Magnet-Designated Hospitals. And Dr. Christine Pence is the lead author. And Christine is a professor at George Washington University. She teaches in the DNP and PhD programs, and she teaches leadership and research. And she did this study as the co-leader of the Washington Regional Research Consortium. And I thought that was really great. Anybody in here can put your hand up in the Washington Regional Research Consortium? Around Washington, D.C., there's a bunch of really smart, I see some hands out there. There's some smart nurses that are doing this together, and I think that's a really good way. Sometimes you think you don't have any support. Maybe you should look outside your own boundaries. So they get together, they're faculty, they're academicians, they're researchers, they're service people, and they do projects in different kinds of research initiatives. And they did this study to describe the extent that nursing research programs in 181 magnet facilities demonstrated 3 foundational categories. The first category is research infrastructure. The second category was hospital research culture. And the third category was building a nursing research program. Okay, so a little bit of background. We all know this is not new news that healthcare continues to advance. And honestly, thank goodness. You know, I'm surprised we didn't hurt more people when we didn't know enough. Nurses worldwide have reported that they do not use evidence-based practice because they don't perceive they have the knowledge. And they also say they don't have the time and the skills. And that creates what we know as the research practice gap, which is a big problem. And the lack of research mentors, the lack of research training, help in disseminating your work, and supporting clinical nurses with time away from the bedside to do these things are important. So what did they find? They used a descriptive correlational survey, and they found these elements that were essential to a nursing research program. And they can come in varying degrees, and we're going to talk about that. Nurses as principal investigators. Now, in my hospital, our projects mostly are questions by either clinical nurses or nurses who are interested in leadership. So clinical nurses will just go down and meet the nurse researcher or somebody in the office, and they'll talk about a clinical problem. If it's something that's substantiated in the literature, we're not going to spend a lot of time exploring that. We'll try to pull the literature and help them understand what we can do that are evidence-based interventions. But if it's something we really need to learn something about, we're going to help them try to design a study. If I looked at my staff and I said, well, here, you go fill out this paperwork for the IRB and you come back and see us and we'll turn it in for you, I'm never going to have anything going on. Come on, guys. I mean, have you ever looked at IRB paperwork? It's a little complicated. And it's intimidating. And so we mentor them through the whole process. Every step they have a mentor. The availability of resource mentors cannot be underestimated. One of the things that I appreciate is that we approach it from more of an educational perspective. In Jonah, in the last few years, I have published a lot of different models for support for nursing facilitators. Things from academic service partnerships, full-time nursing faculty on site, part-time people, people sharing nursing faculty or researchers. I know our researcher was an academic service partnership in the beginning, and she was 50% faculty and 50% with us. Then she retired, and now she's with us 50%. So it's worked out really well. In support of our office, though, we've tried to do some creative things, and we don't spend a lot of money. Usually every year I have 1 or 2 PhD students who need clinical exposure and who love to participate in these projects and also get some publications. And they're great at statistics. And so that's a big help for us. They're really good at SPSS. And then the other thing I have is I have an oncology nurse who is a part-time nurse researcher for us, and she's a part-time oncology clin spec. And then I have a doctorate in physical therapy person who is interested in lymphedema for her clinical research, and then she does some work in our office. So that's our office. It's all part-time. It's not expensive. And in the book, I talk about how cheap our office is run. Clear expectations and support about research from hospital leaders. You better believe that if you're the hospital leader and you think something's important, everybody else thinks what you think is important. And I learned a long time ago, even for my first magnet designation, you cannot delegate your responsibility to be involved and have people think that it's part of the culture unless you're personally involved. And so that goes from role modeling your participation in research projects to sometimes role modeling your support and work with publications. Clear expectations about the support for all over the hospital. Research education at multiple levels. One thing the second magnet surveyors told us in Lexington was, we had a great survey, but they always like to tell you a couple things before you leave. They said, you all have a great organization. You need to try to look in the future at tying your clinical advancement model, your professional practice model, in with your research program a little better. And they were really in 2 silos. It was a good observation, and we took them at that. So what we did is we went back and looked at our Nursing Leadership Council, and we said, help us figure out how to integrate research into our clinical ladder. And they did. And so we decided that for a level 3 or 4, which are our top 2 levels, you have to actively participate in nursing research. And we give them lots of opportunities. I mean, who doesn't have something going on with COTIs? I wish I didn't have any, but I do have a few every now and then. And so there are opportunities, and it's good for them because it sort of forced some of my best nurses that I was paying a lot of money for the clinical ladder to get involved with something really important for our patients. So then we had to take a step back and we think, okay, we got to teach these people what we want them to know. The very first thing we did was teach the leaders, because if you teach the staff and the leaders stop it at the department level, you're not going to get buy-in. And so our nurse researcher created a program for our leaders, and we had a program so we could all have a common understanding, because I have managers, leaders who have been out of school a long time, and you go to different schools, and different schools have different philosophies. And so we taught a couple of hours, a program for them, sort of a research intensive. And we talked to them about our expectation for them to be open to staff when staff bring up ideas at the unit level to help facilitate them to move on to the nursing research office. And then we developed a program that we teach now several times a year to our nurses, and it's open for people who want to advance on the clinical ladder so that they can come to the research program. Research committees with nurses as members should be active. Research assistance and financial resources are important, and like I said, there's a large range of financial resources. You can go from very expensive to not expensive. You don't have to be a big hospital, and you don't have to have a big university to have a research program. Paid time for research is desirable, but honestly, I don't do it. You know, I would like to do it now if I ask somebody to come and do something, but otherwise they just seem to be able to work it out. They're very creative and they're smart, and we try to take a lot of the time burden away from them. And dissemination of scholarly outcomes is an opportunity. And honestly, at Baptist Health, it is an expectation. When you start a project with us, our staff know that the expectation is that you're going to publish it, or that we're going to try to help you publish it, and that we want to help you disseminate your work. And we want to adopt your work because we want to improve based on what you've done. This is a picture of my book. Yeah, I hate to say this, but I'm going to do it anyway. I was really wanting to write one on sex, murder, and romance in a hospital. But I'm still working. And, but I'm gathering information every day. Although I got to change the descriptions because my staff and my people I work with are fairly well known. So I ended up writing a smart book first, but our first author on that's our nurse researcher, and we had this come out in October, and I'm very proud of it because it's an easy read. Our target audience are nurses in leadership positions and nurse faculty, because what we've done is we've tried to take the mystery out of research and just bring it down to practical clinical examples, and we have examples all over from our hospital, with permission from our nurses, where we've shown things that they've done. Here are some things from the book, though, that I wanted to point out. One is, a mentorship approach to research is a very friendly, safe way to manage a research project or a research office. Staff are encouraged to bring clinical questions to the research office. They don't have to ask their manager to go down and see the research office. They may have something they just want to talk about and see if they can kind of frame it to even present it to their manager, although managers do facilitate that. Statistical support is provided, and it's very important because statistics can be daunting. Rewards and recognition are ingrained in the culture. It's that generous leadership concept, and I'm really, really passionate on that. Leaders are expected to support inquiry. That is a role expectation of my directors when I do their evaluations, what's going on your unit. Staff are expected to present their outcomes and to implement changes. We have to teach people how to do that, though. Believe me, speaking before an audience is a big deal. I only practiced this about 50 times. And get this, I read the TED Talk book on Tuesday, and I thought, well, shoot, I've already done my presentation now, so whatever. I thought the next 4,000 smart nurses I speak to, I'm going to be better because I read the TED Talk book now. So, but we want to teach people how. And so what we do is we teach people how to do PowerPoint. We teach them how to write abstracts. We let them practice in front of us in an auditorium with a few friendly people that will help them. And we then let them present their work at our hospital research consortium, where they can present to others so that they can understand how to do that in practice. And now they're presenting all over the world because they're really smart. They didn't need us very long, and now they're out there doing good things. I wanted to show you some trends as an editor that I feel like are emerging issues for the next few years, because I want you to think not only about the studies I've covered and some of the topics I've covered, if you think about your own practice setting or where you are and what you could submit for publication, but here are some things I think we all need to be worried about in the future, and I'd love to have some articles on this. One thing I will tell you, I'm a member of an International Nursing Editors Association. They, over and above, would appreciate if you have an interest in something and publishing in their journal, and you have a topic you want to ask them if they're interested in, you should feel free to email the editor. Almost all of them will answer you back fairly quickly and be supportive and either tell you if they think it's a good fit or not, and sometimes give you some ideas about something that you may want to include in your manuscript that would save you some time or even help your potential for success in being accepted. So I would encourage you to do that. I know I get emails. I advertise my Joni email on our website, and I really don't mind at all. And if it's not a good fit, I try to tell you why not and maybe give you a suggestion. So that is something that you need to think about, and sometimes people don't, and I really would encourage that. One more thing about publishing. Sometimes it's not that you don't have a good idea, it's that a journal's published a lot on that topic in the past few years, and we get something called saturation, where we just feel like, you know, we want to appeal to the readers, we want to publish things that people are going to want to read, and we want to make sure that we haven't fixated so much on specific topics that we're not of interest to as many people as possible. So it really is important to make sure that you go back and look at some of the recent publications on your topic in your journal too. That's another hint. Population health is not going to go away. We're going to have decreasing reimbursement, we have increased chronic conditions, we're going to have an aging population, and we all need to be worried about it. And my opinion is that nurses should be leading it, and we need to see projects from nurses with financial and clinical outcomes that show what difference we're making. Chronic condition management, both in inpatient and outpatient care settings, including physician practices, and oh, that brings up a topic. You know, when I went to nursing school, nobody told me I was going to be supervising employed physicians who didn't want to be employees. That in itself You talk about stress, that's the most stressful part of my job. And you know, I don't see anything published on nurses' roles in leading physician employees. You know, I'd love to see something on that because all of us could learn from that. Believe me, I like some good tips. And so that would be something interesting to see some publications on. If you have a big responsibility for a group of employed physicians and you've been able to achieve some great clinical outcomes, and you know, maybe you've implemented shared governance in that environment or something, submit something. Prn models. This is something I'm particularly interested in because as I go back and look at what's been published in the literature, we have spent a lot of time with new graduate transitions. And I don't think there's anybody in the room that doesn't think that a new graduate doesn't need some kind of a transition program beyond orientation. But yet we've taken these really experienced nurses who graduate nurse practitioner programs and we turn them loose to whoever and expect for them to know how to be a nurse practitioner the day that they finish, and they don't. Now, I've had a couple of really good models that have been submitted to JONA. One early model from MD Anderson when Barbara Summers was the CNO, and they did a great job, and they have an oncology transition program for their nurse practitioners because they have such a heavy emphasis in oncology. But I think we all need to look at testing some new models for nurse practitioners because think about it. They go to work in physician practices, they go work in clinics, sometimes they run clinics, they work in hospitals, and we really don't transition them at all, and their support is kind of minimal at times. Workload and outcomes for nurse practitioners are important. There's a young nurse practitioner at Vanderbilt named April Capu, and she's been very prolific with her organization and with her nurse professional body in publishing some work on workload, but I'd like to see some more. Workforce shortages are going to continue to be an issue, and we need to see more work on that, and the new strategies for retention and engagement. I think we need to see some new strategies that involve social media. It's going to stay, it's going to be here, we need to figure out how to incorporate it. If you've done that, you should publish it. Applications for high reliability. About 2 years ago, 2.5 years ago, my system adopted the Joint Commission program for high reliability, and honestly, it's a really good framework for process improvement. Now we've got over 30 daily huddles that are going on the units. On the units that are 24-hour, they do huddles a couple of times a day. But it teaches the staff about metric management, and honestly, it's another way for staff to be providing suggestions and feel engaged. And so it's got a dual benefit in relation to outcomes. But I think more on outcomes and how we're able to monitor, achieve, and sustain outcomes. Staffing models and models of care for outpatient settings are emerging issues, and we need to have more work on that. When we talk about violence in the workplace, this is one that's particularly personal to me, and I've got about 6 minutes left, so I'm going to tell you a quick story. I'm from Kentucky, and a lot of people smoke in Kentucky. It decreased a little bit. We've gone from like 30% to 25% of the adults that smoke. And about a year and a half ago, I had a staff nurse in one of our magnet meetings that spoke up, and she said, Karen, she said, I'm scared of my patients sometime. And she said, we're a no-smoking campus, like all the hospitals in Kentucky, so what we've done is we pushed the smokers out to the sidewalk. And I kind of ignored it all these years because you don't want to make the smokers mad. You won't have any patients left if all the smokers are gone. And plus, I got some good employees that still smoke, although I'd like for them to quit. And so I felt bad because I thought I should have done something sooner. So I went to the literature, and I found a lot of great work from the VA system, and I know there's some VA nurses here, on something called patient wandering, because I thought, strategy. If I go into this project and I try to get everybody to quit smoking so they don't go outside, I'll never live through this project. But if I go into this project and think about how can I help make my nurses safer and how can I help make my patients safer, I can do it. And so I labeled it No Patient Wandering. I got the support, and one of my nurse colleagues from Baptist is here today from one of our hospitals, Mindy Blair. I got the support of my nurse colleagues from the other hospitals, and we decided this was a nurse-led initiative. And so we created a policy called No Patient Wandering. We solicited the support from our CMOs, our physicians that are our medical officers, and we went to a corporate physician advisory group, and we got their support. We went to all the med exec committees. A year ago, this coming July, Baptist Health went No Patient Wandering. What we do is, if you come to the unit, we warn you ahead of time, we communicate like crazy, we let the public know, we let the doctors know that we have a No Patient Wandering policy. When you're admitted to a unit, you stay there unless you're going for a diagnostic procedure or a test. If you leave the unit for a brief time after you've been told by the patient access people, by the nurses, we'll give you one shot to come back. And we warn you again. If you leave for an extended time or you leave twice, you're discharged AMA by the nurse. And what we told the emergency room is we said, make them wait. You know, if they come back in, make them wait, because they don't need to be here that much if they can be outside that long. Because I'll tell you, what I did is I pulled the patient wandering incidents from my own hospital, and I'll just tell you 3 of them. 1, I had some crazy guy in a gown out on some neighbor's yard in the periphery of the subdivision. 2, I had a patient that went outside to smoke and fell and broke her hip. And 3, and this is the most humiliating, I had a young patient who went down to a gas station down the street. She overdosed, and she came back in my emergency room with an armband on. And that was bad. And so we decided that we needed to support patient safety. We told the story, we got everybody on board, and the whole system went no patient wandering as of last fall, and I'm so proud. And it was totally nurse-led based on one nurse in one meeting making one suggestion and finding the literature to support it. So now that's my project for this year. I'm waiting until July till I get a year's worth of data, because in the month of July I had 14 AMAs, and this past month I had none. And we're going to write that, and we'll publish it and put the toolbox out and all that kind of stuff. And you know, it's awful when you used to think about safe work environments. I used to worry about back injuries, and now I got guns, knives, and drugs. So, I mean, really, we need some good work on some of these emerging issues. Nurse managers, we've talked about a lot, and the changing roles of nurse executives. I know my role's changed a lot. I love being the chief operating officer. Being in charge is great. And, you know, go for it. And then systemness. We're all facing systemness, and we have to define what that is and what that means for nurses. Okay, so, oh, whoops, I went backwards. Oh, I went way backwards. Okay, now, this is one I wanted you to see. If you've never published before, this is something I did with Sigma Theta Tau. It's inexpensive, it's almost 3 hours, and it is soup to nuts with 3 other editors from the very beginning of constructing a manuscript until the end of working with an editor for publication. So I encourage you to look at that. Sigma Theta Tau does some great CE studies, and I really appreciate this one because it's very easy to follow. This would be good for students. If you've got students or nurses in your organizations that want to do something, you can find it on their website. It's a bargain. It's $33 for almost 3 hours. So, and I don't get a penny for that, but they were great. Okay, so what are the key takeaways? The key takeaways are nursing managers are pivotal to every component of nursing practice, and we cannot ignore how important they are in almost every way. Nurse executives have to become more involved in the transition of APRNs. We want them to do great, and we want to help them. And we own them. They're nurses. We must have a healthy work environment to support nurses to do the best they can, and that includes retention strategies, recruitment strategies, patient care quality, and safety. And the last thing is that nurse leaders must establish cultures to support research. If you think it's important, they'll think it's important, but it has to start with you. So I'm going to challenge you today because this is all about inspiration. I hope I've inspired you to publish. I hope I've inspired you to go back and look at your own work, because you may not think it's a big deal, but you got lots of things you can write about, and people will find it really interesting. There are a million things. Look in the literature every chance you get, because you'll get all kinds of inspiration and ideas. And this is a picture, and believe it or not, this is right outside the airport in Lexington. We have a lot of horse babies right now, and it's a great time of year, and so I just wanted you to know, I'm a normal nurse in Lexington, Kentucky, and I've had an amazing career. I have had blessings. Doing this on my birthday today is a blessing. And I'm challenging you all to publish, and you send something to the manuscript that you want, because seeing your name in print as a normal person is one of the best things you can do for your career. Have a great meeting.